All right, guys, this is take 2 of this lecture video. Power went out in the middle of the other one. I tried to restart it. Power went off again. Anyway, so we're just gonna do take 2 and have the whole video in one file. So with that being said, we're talking about ventilation of the neonate. So we talked in our previous lecture, the one before the exam, about how neonates that crash hard and fast. By the same respect, they bounce back faster with immediate intervention. So we recognize the signs of respiratory distress. We need to intervene as quickly as we possibly can. Often those neonates just need supportive care until the underlying condition is corrected or reversed, and then they recover rapidly. Okay? Many of the criteria that we use to classify a neonate as being in respiratory distress mimics adults. However, they're slightly different and they can change a little more rapidly than adults. So remember we talked about normal values for a newborn up to 1 hour of age are off or slightly lower across the board than normal values for an adult. So normal pH for newborn up to 1 hour of age is 7.525 to 7.35. Normal CO2 is 30 to 40. Normal PO2 is 50 to 70, and normal bicarb is 17 to 23. All of those slightly lower than what a normal adult value would be. After 1 hour of age, we are progressing towards normal adult values. pH is 7.35 to 7.45. Sound familiar? PCO2 35 to 45. Again, what we're used to. PO2 of 80 to 100. That's normal. And then the bicarb remains a little bit low because remember, bicarb is part of the renal system. It's a compensatory system that helps correct what our pH or our acid-base balance is. So that bicarb, when it starts changing, it takes a little bit of time to do that. So even at 1 hour of age, 17 to 23, but progressing toward normal range in the next hours to days of life. Signs of respiratory distress. So in general, here are the signs of respiratory distress. CO2 of 55 and rising, okay, same as adults. PO2 of 50 and falling, same as adults. And pH of 7.3 and falling, okay, going hand in hand with our CO2. However, we don't wait on these blood gases to start getting bad before we intervene. In general, with infants, you don't wait for blood values. If the baby is circling the drain, if the baby's having retractions, cyanosis, grunting, nasal flaring, tachypnea, all of those things, we want to intervene immediately, because if we can correct or reverse the underlying process, then we won't have to go any further in our intervention. Okay, infants have cardiac arrest because they have a pulmonary issue most of the time, unless they have a congenital heart defect. Their cardiac arrest comes because of a pulmonary issue. So if we can intervene and break the cycle of that pulmonary issue, then that baby's process will reverse. They'll go into normal adult circulation and breathing, and everything's great. Infants are very resilient, but they crash hard and fast when they do. If an infant's PO2, okay, their oxygen level is out of range, but they have a normal CO2, then usually giving supplemental oxygen from a nasal cannula or blow-by oxygen is enough to help reverse the process. It will correct the problem. If an infant's PO2 and CO2 are both out of range, then mechanical ventilation or nasal CPAP or some other further intervention is necessary to reverse the process. So, we just have to assess our baby and decide what the best intervention is, knowing that we intervene and we correct the issue, that might be all we have to do. Now, if you do have to go into further resuscitative efforts, the umbilical artery and venous lines come into play. Okay, this is the best way to monitor hemodynamics, draw blood gases, and give medications and fluids to our newborn infant that needs more intensive care. Okay, we have one umbilical vein. It's a very, very big vessel, and two umbilical arteries, usually. Smaller vessels, but still are opened and patent in our newborn baby. They are already there. Okay, they are open. They've been being used for the whole time that baby's been cooking inside mom. So at birth, even up to an hour or two of age, you can still insert catheters into these vessels as long as you have enough of that umbilical cord left. And it is the best way to draw blood and give medications. You can use your umbilical artery catheter for blood pressure measurements. Okay, so for hemodynamic monitoring. You can use your umbilical artery catheter for drawing blood gases. Okay, non-invasive, you know, you don't have to stick the baby. It's still invasive, but you're not sticking the baby over and over in their teeny tiny arteries. Okay, it's less invasive than trying to place a peripheral arterial line or a central venous line in these babies who are newborn, fragile, and have very small vessels. Umbilical artery and venous lines can be used for several days. Okay, we have to treat them very cautiously and gently to make sure that they remain patent. Your umbilical artery catheter, it has to be heparinized. Okay, so we usually don't draw regular labs off of the umbilical artery line, only blood gases. Okay, and we're gonna watch a couple of videos on placement and how they work, so you guys can kind of visualize it. It will give us hemodynamic monitoring. Okay, the big risk with umbilical artery catheters is they have a tendency to clot off. Okay, so we have to heparinize them and keep a continual heparin drip. This puts the baby at risk for intracranial hemorrhage or brain bleeds. So we always have to be cognizant of that. The only patients that you cannot put umbilical artery or umbilical venous lines in is patients that have some type of gastric issue, a congenital defect in their abdominal wall, such as gastroschisis or encapsulation. Patients with congenital diaphragmatic hernia, you usually can't put umbilical lines in them. Sometimes you can, sometimes you can't. Patients with peritonitis or any other abdominal lesion or defect that would prevent you from being able to access the umbilical arteries. So give me a second. I'm going to pull up this first video.
Cut the umbilicus horizontally, leaving behind a 1 to 2 centimeter stump. You'll then be able to visualize the two arteries and the vein. Next, use the probe to dilate the artery and proceed to insert the catheter to the desired distance. Ensure the correct cannulation of the umbilical arteries by observing the visible arterial pulsation as well as the bright red blood withdrawn into the syringe. Proceed to check the circulation of both legs to observe any signs of arterial occlusion. We then proceed with the umbilical vein catheterization. Identify the umbilical vein and then proceed to use the probe to dilate the vessel. Then insert the umbilical vein catheter to the desired length. To prevent the UAC or UVC from being dislodged, secure it in place by using the suture. Plaster the UAC and UVC in place and clear all sharps and clinical waste accordingly. Connect the UAC to the probe and observe the waveform. Finally, perform a chest and abdominal X-ray to confirm the position of the UAC and UVC.
The placement of umbilical catheters is an essential technique for the treatment of many newborns in unstable condition. This video will demonstrate the placement of catheters in the umbilical vein and the umbilical artery. Careful preparation, sterile technique, and attention to detail are instrumental in successful catheter placement. We will demonstrate the regional anatomy of the umbilicus, indications and contraindications for the insertion of an umbilical catheter, the recommended technique for catheter placement in both the umbilical artery and vein, selected complications associated with the procedure and suggestions for how to avoid them, and appropriate aftercare of the catheter. Umbilical vein catheterization may be indicated for emergency vascular access, monitoring of central venous pressure, exchange transfusion, and central venous access in infants requiring long-term parenteral nutrition. Umbilical artery catheterization is indicated for frequent measurement of arterial blood gases, continuous monitoring of arterial blood pressure, angiography, and occasional resuscitation. The umbilical vein is considered the optimal vessel in this situation. The contraindications are similar for both vessels and include omphalocele, gastroschisis, omphalitis, and peritonitis. In umbilical artery catheterization, evidence of vascular compromise in the lower limbs or buttocks and necrotizing enterocolitis are considered additional relative contraindications. Within the Wharton's jelly of the umbilical cord, the arteries are located lateral of midline in the inferior portion of the cord, positions 5 and 7 on the face of a clock. In a full-term infant, the artery is approximately 7 centimeters from the umbilicus to where it joins the internal iliac artery. The umbilical vein is a larger midline vessel with thinner walls, located at position 12 on the face of a clock. In a full-term infant, it is 2 to 3 centimeters in length and 4 to 5 millimeters in diameter. After the procedure has been explained and consent obtained from the parent or parents, review the records and examine the patient to confirm that there are no contraindications to catheterization. In your examination, concentrate on the anatomic landmarks. You must then decide how deeply to place each line. The umbilical artery catheter, or UAC, can be placed in a high-lying position between thoracic vertebra number 6 and 9, or in a low-lying position below the third lumbar vertebral body. Here we will describe the procedure for the placement of each type of catheter. There are many acceptable methods for determining the appropriate depth of placement. To calculate the depth for inserting a high-lying UAC, multiply the weight in kilograms by 3 and add 9 centimeters, then measure and add the length of the stump to this value. To calculate the appropriate depth for the umbilical vein catheter, or UVC, insertion, multiply the weight in kilograms by 3 and add 9 centimeters, divide that total by 2, then add 1 centimeter. Standardized graphs for determining the depth of catheter insertion are available, and they are included in the supplement. To ensure the highest level of sterility, the operator should wear a sterile gown and gloves, as well as a surgical cap, mask, and face shield. In addition to these items, most of the equipment can be found in commercially prepared kits and should include skin preparation solution, a surgical drape with central opening and/or sterile towels, sterile 4x4 gauze, a 3-way stopcock with a lure lock, one for each catheter port, a 5 or 10 milliliter lure lock syringe, one for each port, a number 11 blade scalpel, saline or heparinized flushing solution, straight iris scissors, 3 mosquito hemostats, 2 smooth curved iris forceps, 1 toothed mosquito hemostat, an umbilical tie, suture, and a needle driver. There are numerous types of umbilical catheters from which to choose. A 5 French arterial catheter should be used in infants weighing more than 1.2 kilograms. A 3.5 French arterial catheter should be used in infants weighing less than 1.2 kilograms. Arterial catheters should have a single hole and be as non-thrombogenic as possible. The umbilical vein catheter should be 5 French for infants weighing less than 3.5 kilograms and 8 French for infants weighing more than 3.5 kilograms. Consider using a venous catheter with side holes when the catheter will be used for exchange transfusion. Otherwise, venous catheters can be single or double lumen and should have one hole. The infant should be placed in the supine position on a radiant warmer. The infant's arms and legs should be secured to avoid movement that might contaminate the sterile field. Sedation is generally not needed because the skin is typically not cut or punctured with a needle. Make the necessary measurements to estimate the depth of catheter insertion. After you are fully scrubbed and garbed to perform the procedure, attach a stopcock to the hub of each catheter and fill the system with flushing solution. Be sure each stopcock is in the off position. Ask an assistant, who need not be wearing a sterile gown, to grasp the cord by the cord clamp and apply traction vertically. Apply antiseptic solution to the cord and surrounding skin. Apply sterile towels or surgical drape in such a way that the patient's face is visible, then wrap the cord tie around the base of the umbilicus and tie with a single knot. The knot should be tight enough to prevent bleeding from the cord, but loose enough to allow the catheters to pass through the vessels of the cord. Cut the cord horizontally with the scalpel, approximately 1.5 centimeters from the skin. Take care not to cut the skin that is at the base of the cord. Ask the assistant to remove the cut cord and clamp from the field. Identify vessels within the cord. Control any bleeding by adjusting tension on the umbilical tie and by blotting, not rubbing, the freshly cut surface. It is feasible for a single operator to place an umbilical catheter successfully. However, we will describe and demonstrate the procedure for the operator working with an assistant donning sterile attire. The assistant should use the toothed mosquito hemostat to grab the side of the cord near the artery to be cannulated, and should avoid grabbing the artery. Clamp a curved hemostat to the opposite side of the cord. The assistant should apply traction to these hemostats in opposite directions to stabilize the cord. Using your non-dominant hand, place the closed or pinched tip of the curved iris forceps into the lumen of the artery to a depth of approximately 0.5 centimeters. Keep the tip closed on initial insertion and then remove the forceps. To dilate the artery further, place the closed tip of the forceps back into the artery, insert to a depth of 1 centimeter, and allow the forceps to open slowly. Leave the forceps in an open position for 20 seconds to dilate the vessel completely. Use your dominant hand to grasp the catheter 1 centimeter above the lumen using the other mosquito forceps, or using the thumb and forefinger, slide the catheter between the tips of the forceps within the umbilical artery. Using a firm, steady motion, pass the catheter 1.5 to 2 centimeters into the artery and remove the indwelling forceps. Grasp the cephalad portion of the cord with the toothed mosquito forceps and apply traction in the cephalad direction to assist in passing the catheter deeper. Once a depth of 5 centimeters has been reached, draw back on the syringe to ensure the blood is able to flow. As the catheter is passed to the predetermined depth, you may encounter resistance at the curvature of the vessel, approximately 6 to 8 centimeters in depth. The vessel should slowly relax, not pop, as you apply constant pressure. Confirm placement with radiography or an ultrasound image. A low-lying catheter should be at lumbar vertebra 3 to 4. High-lying catheters should be at thoracic vertebrae 6 to 9. Secure the catheter with a purse string suture. Avoid puncturing the catheter, the vessels, or the skin. There are several stages at which you may encounter difficulty with insertion. If the catheter threads to only 3 centimeters, the umbilical tie may be too tight. Loosen the tie, redilate the vessel, and reinsert. If insertion is easy but there is no blood return, or if you sense a pop after entering the lumen, the catheter may be in a false track outside the vessel. Remove the catheter and prepare the other umbilical artery for insertion. If you encounter resistance at 6 to 8 centimeters in a full-term infant, the catheter may be at the curvature in the umbilical artery, curving around the bladder before it enters the internal iliac artery. Apply gentle pressure for 30 seconds. Some experts recommend positioning the infant on the side, with the artery being cannulated in the superior position, flexing the hip to facilitate insertion. In our experience, it is often best to move on to the second artery if resistance is encountered at this curvature. To insert an umbilical vein catheter, with your non-dominant hand, grasp the cord with the toothed forceps. With your dominant hand, using the mosquito forceps, remove any blood clots from the entrance of the vein. Using the mosquito forceps, introduce the pre-flushed venous catheter attached to the stopcock and syringe into the lumen of the vein and insert 3 centimeters. Gently pull back on the syringe to ensure blood return and proper placement. If blood returns, continue inserting the catheter to the predetermined depth. Obtain radiographic or ultrasonographic confirmation of the catheter position. The ideal position is in the inferior vena cava, near the right atrium. Secure the catheter as you did for the arterial catheter. If the catheter meets resistance before it reaches the predetermined distance, it has most likely entered the portal system, become wedged in an intrahepatic branch of the umbilical vein, or doubled back on itself. In these circumstances, pull the catheter out of the vein approximately 4 centimeters and rotate the catheter as you reinsert it into the vein. Occasionally, this will allow the tip to slip through the ductus venosus. Often it is necessary to repeat this maneuver several times. During an extensive resuscitation, it may be necessary to obtain emergent intravenous access. Immediately following birth, the umbilical vein is the vessel of choice. The procedure is altered slightly from what has been previously described. Prepare the umbilical cord with an antiseptic solution. It is often impossible to create a sterile field in an emergency situation. The operator should don sterile gloves and keep the catheter as sterile as possible. The catheter must be pre-flushed and attached to a stopcock and syringe. If an assistant isn't available, you can tie the cord at the base with a cord tie and cut the umbilical cord 2 centimeters above the skin. Quickly insert the umbilical venous catheter into the umbilical vein to a depth of 3 to 5 centimeters below the skin. In a full-term infant, check for blood return and secure the catheter between your fingers or with tape. It is imperative that the catheter not be inserted too deeply, as it may enter the hepatic vessels, in which medications administered during the urgent situation could potentially cause hepatocellular damage. To prevent clot formation, keep the catheter free of blood by flushing it with 0.5 milliliters of solution each time blood is drawn from the catheter. Solution should flow continuously through the catheter to prevent retrograde flow. Watch closely for evidence of clot formation, including difficulty withdrawing blood samples or decreased amplitude of pulse pressure on a blood pressure tracing. If a clot forms, do not attempt to flush the clot forcibly. Unless the line is critical, it should be removed. UACs can cause or be associated with multiple complications, including but not limited to thrombosis, embolism, vasospasm, loss of extremity, hypertension, air embolism, necrotizing enterocolitis, infection, and bladder injury. If malpositioned, these catheters can result in vessel perforation, refractory hypoglycemia, peritoneal perforation, and sciatic nerve palsy. Complications associated with UVCs include infection, thromboembolism, perforation of the peritoneum, portal hypertension, digital ischemia, and pneumopericardium. When placed in the wrong position, UVCs can cause pericardial effusion and tamponade and cardiac arrhythmias. Umbilical catheters should be removed when complications occur. The length of time an uncomplicated catheter may remain in place is the subject of some controversy. At present, we recommend strict adherence to individual institutional policies until consensus on this important issue can be obtained. The placement of umbilical catheters is an indispensable technique used to stabilize the condition of critically ill newborns. Proper insertion technique and knowledge of potential complications will improve the utility of these catheters in the newborn population.
All right, guys, I know that that was a long video, but it really is very comprehensive, and that's why I wanted you to see that video. So I like that one. All right, so here's a picture of umbilical artery line placement, appropriate line. You have 2 shots to insert an umbilical artery line. Okay, and usually it's inserted all the way up to just before where the ductus comes off, okay, into the aorta. Okay, so you want it to be pre-ductal. You don't want to get mixed blood. You want to have the best chance of having arterial blood possible. So that's high placement of your umbilical artery catheter. Here's a picture of umbilical venous catheter. It has more of a low-lying placement. Okay, so it just, especially for emergency use, just about 7 centimeters in, and that's it. And it'll give you great access for that baby to give them medications, give them fluid, etc. So criteria for neonatal ventilation. Now, all of these things may indicate the need to intubate and ventilate, or at the very least, give them nasal CPAP. The first one's apnea of prematurity. Apnea of prematurity is not the same as primary or secondary apnea. Okay, so primary apnea is when that baby comes out slow to start breathing, but you stimulate them, then they start breathing and they're good to go. Secondary apnea comes after primary apnea. And it's when you stimulate them, but they don't start breathing, you have to intervene further. Okay, those are usually defined in the delivery room, primary and secondary apnea. Apnea of prematurity happens in premature babies who forget to breathe and have to be stimulated to breathe. Their brain isn't mature, and sometimes the lack of development causes the brain centers to not fire on a regular basis. Those babies will lay there and just look at you and not breathe. You give them a little stimulation, they start breathing, they're good to go. Respiratory depression, that's the next one, okay? This is usually medically induced. Okay, mom takes a respiratory depressant drug, such as morphine, heroin, and another narcotic. That could cause respiratory depression. Everything the mom takes, the baby gets. Okay, mom is given narcotics during labor or magnesium sulfate to prevent labor. One of the side effects of mag sulfate delivery is babies are born sleepy, tired, with little respiratory drive. Remember that the baby gets everything the mom gets. Okay, so if it gets into the mom, it's going to pass through the placenta into the baby. And it's gonna affect the baby the same way or even have a higher effect. Okay, that baby may need to be intubated for a short time until the drugs are out of their system or they wear off. Infant respiratory distress syndrome, we covered that in the lecture before the exam. IRDS, what causes it? We talked about a lot of different things. The biggest cause of IRDS is lack of surfactant. Okay, these babies have nasal flaring, retraction, cyanosis, ground glass appearance on chest x-ray. They have a lack or depletion of surfactant. Okay, if we did an LS ratio, it's less than 2:1. IRDS can also be caused from infection. Okay, anytime the baby has infection or pneumonia, it could deplete the surfactant. Okay, so all of that leads to respiratory distress and they may need to be ventilated. Meconium aspiration syndrome. Okay, it's different than meconium aspiration, first of all. When a baby aspirates meconium, we know that it is thick and sticky. It can form ball valve effect, so they have hyperinflation. But the meconium aspiration syndrome is when it's left untreated and that acidic meconium starts to damage the lungs. Okay, meconium below the cords is aspirated into the fragile airways. It's acidic and sticky and it's hard to ventilate them and it continues to cause tissue damage. Pneumonia, okay, so babies can support their own ventilation and is intubated until the pneumonia can be treated and resolved. We just give them support. Okay, usually babies get pneumonia because the mom had an infection such as group beta strep infection. Beta strep pneumonia can give you a very, very sick neonate. Once they're treated, they usually reverse and come out of it. Persistent pulmonary hypertension of the newborn. Okay, so for unknown reason, the baby falls back into fetal circulation. Okay, this happens in term or post-term infants. Most often they are suffering from asphyxia for some reason, meconium aspiration syndrome, sepsis, congenital diaphragmatic hernia. Okay, so when there's a hole in the diaphragm and the intestines actually migrate up into the chest, causes the affected side, that lung doesn't develop. Okay, so you have pulmonary hypoplasia on that side. Infants that have severe pulmonary vasoconstriction, which leads to increased pulmonary pressures, decreased blood flow to the lungs. With the increased pulmonary pressure, the right side of the heart pressures rise, foraminal valley opens up, ductus arterius opens up, it allows fetal circulation to reestablish. Then we have ventilation to perfusion mismatch, and it leads to acidosis and hypoxia. So we need to intervene. We need to figure out how to get the pulmonary vasculature dilated so that fetal circulation can switch to adult circulation. Right side of the heart becomes low pressure, left side becomes high pressure, all things return to normal. And then the last one we list is intracranial hemorrhage. And we're gonna go into that in more detail later. I think I actually have a whole portion of a lecture on it, but it's when there's 4 ventricles in the brain and their vessels in those ventricles are very, very fragile. And if there's bleeding into the brain, it could cause damage to the respiratory drive, okay? So those are all criteria for neonatal ventilation. Now that American Association for Respiratory Care publishes clinical practice guidelines for ventilation for neonates, okay? These are the 6 criteria for mechanical ventilation. First one's apnea, we just talked about that. Respiratory failure, okay, so respiratory failure, according to AARC, is defined by an increase in FiO2 and CPAP greater than 12 centimeters of water pressure with no resolution of the underlying respiratory distress. It's defined by physical exam and also lab criteria. So signs of increased work of breathing, cyanosis, grunting, retractions, all of those things that indicate respiratory distress in our neonate. combined with a pH of 7.2 to 7.25, a PaO2 of less than 50, a PaCO2 of greater than 55, and then altered neurological status. All right, yeah. The next one's altered neurological status. Okay, so babies can't really answer questions, but if they aren't reacting to stimuli like they normally should, they're having apnea, if they have intracranial hemorrhage, congenital neuromuscular disease, all of these things fit into that criteria of altered neurological status. If they have a decreased functional residual capacity, okay, decreased lung compliance and or increased airway resistance from respiratory distress syndrome, from meconium aspiration, okay, from diaphragmatic hernia, from sepsis. Okay, the next one's impaired cardiovascular function. Usually this is either persistent pulmonary hypertension of the newborn, which we can reverse. Okay, remember we have to dilate that pulmonary vasculature and get circulation where it's supposed to be going. Okay, congenital heart defects, which can be diagnosed and then usually fixed, or at least get a plan. So both of those impair cardiovascular function. And then post-op recovery. And this is usually as a result of anesthesia. So you have to get that anesthesia reversed or let the baby wake up and rid that anesthesia from their body. Now there's different levels of support. The most basic being, and I didn't put it on here, but oxygen delivery by blow-by, okay, little mask, or nasal cannula. Okay, so in the delivery room, we can do blow-by oxygen if it reaches that point. And we can do it with our T-piece resuscitator, or with our flow inflating bag, or with a little mask. Beyond the delivery room, if that baby just needs a little bit of oxygen, okay, so their PO2 is staying low, or their SpO2 is staying low, but everything else looks normal, we can give them nasal prongs, put a little bit of oxygen on that baby. All oxygen delivered to infants, especially if you're in a NICU, is going to go through a blender. So you might see a patient on a half a liter, 1 liter of oxygen at 30% or at 21%. Maybe they just need that oxygen for a little stimulation to make them breathe. So it's just a different world. So just keep that in mind, that it always goes through a blender. The next level of support is CPAP. Okay, so CPAP can go through a ventilator, or it can go through a bubble CPAP machine, which we're going to do in lab. And I'm going to show you a picture of it here on the next slide. We always give nasal CPAP. Why do we give nasal CPAP? Because babies are obligate nose breathers. Okay, they breathe through their nose. If a baby is breathing through their mouth, there's some other anatomic issue going on. So nasal CPAP, bubble CPAP, also really convenient because you can give them a pacifier. They can suck on a pacifier while they're on nasal CPAP. Along with that, you can give them glucose on that pacifier, and glucose actually in newborn infants causes kind of a euphoria, and it helps decrease pain receptors. So if you're doing a blood draw or some other procedure that might cause that baby pain, you can give them glucose, and it helps actually tricks the body into not recognizing the pain. This is a picture of bubble CPAP, and we're going to actually do this in lab, so I'm not going to go into super deep detail, but in a nutshell, positive pressure is generated by bubbling gases through sterile water. The bubble created by this flow adds a little oscillation. It also adds pressure. You can see this has numbers on it, 10, 9, 8, 7, 6. However deep, this is your expiratory limb, however deep this is in the water is how much CPAP you're giving. Okay, you need to make sure your water level is consistent, and then you just set this. It goes through a heater, so it's heated, humidified, it's bubbled through water. It's very gentle CPAP. We can also use heated high flow nasal cannulas on our infants or our newborns. Okay, so high flow nasal O2 for infants has been shown to be very effective. Use the devices decreases ventilator days, been shown to reduce the need for intubation. Following a failed CPAP trial, they might try nasal or heated high flow nasal cannulas. Flow of greater than 1 liter per minute is generally considered high flow for a neonate. So whether it's heated or not, okay, if it's greater than 1 liter per minute, it's high flow. If it's super saturated and heated, it's maximum and helps maximize mucociliary clearance, helps reduce inflammatory response. And there's a lot of studies, depending on where you look and who did the study. Some say it's better than nasal CPAP, some say it's worse than nasal CPAP. So again, it's just depends on who did the study and what they were looking at. You can use BiPAP in neonates. I have not seen it very often. But BiPAP, you guys, just as a refresher, and actually we're gonna go over BiPAP in lab in a week or so. BiPAP augments spontaneous ventilation with your IPAP and holds the alveoli open with your EPAP. Okay, so you have two separate levels of support. You may see this in NICU. I have never seen it in NICU, but it's possible. And then we have our mechanical ventilators, and all three of our mechanical ventilators that we have in our lab, the three big ones, the three microprocess mechanical ventilators, can go from premature infant all the way through adults. 20 years ago, if ventilators said they went from premature infants to adults, they usually were not telling the truth or they didn't do it very well. I can tell you with confidence that the ventilators being built and produced and sold in the 21st century, in 2024, 2023, whatever, they can do it really well. And it's because of the microprocessor in them, because they're very fine-tuned, because they have increased flow detection capabilities. They just are very, very, very sensitive. They can measure exhale volumes, they can measure pressures to a very small level, and that's what makes them able to do that. So we're gonna learn how to set up all three of our ventilators in neonatal mode, but we're gonna do it in the lab. So we're not gonna talk about that much today. One really cool thing that the Servo-I and the Servo-U do, and then other ventilators are coming out with the capabilities, is called NAVA, or Neurally Adjusted Ventilatory Assist. Okay, what this is an orogastric tube with electrical sensors on it is inserted. And these electrical sensors basically sit at the level of the diaphragm. So if you see this here, these are little electrical detection devices. When the diaphragm contracts, these electrical impulses pick it up. Okay, so they know when the nerve contracts. It delivers information back to the ventilator and says, hey, the baby is taking a breath. Okay, so we need to coordinate with that breath. So central nervous system, the phrenic nerve, diaphragm excited. So this is the nerve impulse, how it travels. Central nervous system says breathe, phrenic nerve travels to the diaphragm is excited, and the NAVA catheter picks up that excitation. The diaphragm contracts, the chest wall and lung expands, and the airway pressure, flow, and volume is augmented, or we assist, so that baby gets a little bit of extra flow. When the diaphragm relaxes, when the impulse is gone, the flow stops. Okay, making it easier to exhale. Okay, great thing. You might see this being used in NICUs that use the Servo-U or the Servo-I. Okay, so for our indications for ventilation, you again have to consider patient history and present clinical situation. Okay, babies can tolerate mild hypoxemia and acidosis. That's why PaO2 value of less than 50, that's why we use that, okay, and not less than 80. That's why we use a CO2 less than 50 or greater than 55 and a pH less than 7.25, okay, because they can tolerate this mild hypoxemia and acidosis, but once they're getting there, once it's still going down, that's when we need to intervene. Color change, as far as intervening with supplemental oxygen, is probably a better clue. Because by the time you get your result of your ABG, your infant may have crashed already. When we are talking about typical ventilation setup, okay, controlled ventilation, we use time cycle pressure limited ventilation. Okay, this is a thought process change. We use time cycle, okay, so we set an I time. Pressure limited, we do pressure ventilation. Okay, we want to limit the amount of pressure that that baby is getting. We also, it's very inefficient for us to try to set tidal volume for these babies because the tidal volume might be 5 or 6 for our premature infants. For our newborn, normal newborn, it might be 20. Those tidal volumes are so small, it's hard for the ventilator to be very accurate when delivering them. But we can set a pressure to achieve, and then we can read the volumes off. So time cycle, okay, we want to set an inspiratory time, pressure limited ventilation. Why do we use time cycle pressure limited? So if there's no real evidence against volume modes, okay, you may see it used. But historically, we use pressure ventilation because we want to protect these very small, young, and fragile lungs. We want to minimize overdistension of alveoli. Small pressure changes result in large tidal volume changes. Okay, so we go up by 1 or 2 at a time. We go down by 1 or 2 at a time. If you have an infant-specific ventilator, it's easier and cheaper to manufacture pressure controllers, okay, or pressure generators. We also have to account for uncuffed endotracheal tubes. In infants, we do not use cuffed tubes. We use uncuffed tubes, so there may be, or usually is, a leak. If we're trying to volume ventilate, we need to compensate for that leak. If we're pressure ventilating, we don't have to compensate because the ventilator is going to hit its set pressure and then it's going to shut the vent off or shut the breath off. Neonatal lungs also have lower compliance, so small pressure changes result in these large tidal volume changes. So all of these lead to pressure ventilation is preferred. Might not be all that you always see. It might be not 100%, that's all we use, but it is preferred. Ventilator setup. And again, we're going to go into this more in lab, but we set a respiratory rate. So normal starting respiratory rate for intubated infant is 40 to 60, right? That's just their normal respiratory rate. Okay, if it's 40 to 60, this makes total cycle time, okay, inspiration and expiration, 1.5 seconds or less. If you remember, Mr. Mulholland talked to you about time constants. Okay, so time constants reflect the efficiency of lung inflation. Time constant equals lung compliance times airway resistance. They can range from 0.05 seconds to 0.25 seconds. And you need 3 time constants to exhale 95% of the breath. So, inspiratory time in neonates, in newborn infants, is usually set between 0.25 seconds and 0.4 seconds to start with. Then we can increase it or decrease it depending on our total cycle time. Okay, hope that's making sense to you guys. This is one of those moments that I would look out if we were live and see how you guys are doing with this. But remember that we use shorter I times for neonates because we have way faster respiratory rates because their normal respiratory rate is faster. Peak inspiratory pressures. Okay, starting peak inspiratory pressure is kind of an educated guess. If you are in the NICU waiting for a baby, there should be the person intubate or the person bagging that baby while on their way to you should have a pressure manometer on their resuscitation bag. And we're going to look at those resuscitation bags in lab and also in NRP because it's super important to know what pressure you're ventilating at. Whatever pressure they are using to ventilate the baby with the bag is what you should start your ventilator at. Okay, look at the average pressure it took to give good bilateral chest rise, improve color, and give equal breath sounds. Start there as your initial peak inspiratory pressure on your vent. Okay, you can also use graphics. Okay, you want to make sure you're not over distending on your pressure volume loop. But a good rule of thumb for starting peak inspiratory pressure is whatever it takes bagging them to move the chest bilaterally. Positive end expiratory pressure or PEEP, starting at 3 to 5. That's normal. Okay, normal physiologic PEEP. Optimally, you want to establish and maintain functional residual capacity. We do not want to hyperinflate that baby. We do not want to cause air trapping. Okay, if we give too much PEEP, we're going to increase pulmonary vascular resistance and decrease venous return. We're going to reduce cardiac output and increase dead space. We don't want to do any of that stuff. We can also cause traumatic lung injury. So we start with 3 to 5, and then we evaluate and change as we move forward. If your ventilator allows you to set flow rate, we want to set that flow rate enough to meet inspiratory demand of the patient for both the machine and spontaneous breath. Some ventilators will automatically set the flow rate, and some of them you will set a flow rate for it. Okay, so we want to meet inspiratory demands, we want to observe the patient, and we want to use graphics to set our flow rate. FiO2, we want to try to avoid FiO2s greater than 60% because it causes O2 toxicity. O2 toxicity can cause oxygen-free radicals. It can damage the eyes. It can cause all kinds of other issues. So whatever that patient needs to keep their oxygen saturations in a normal range for their age, and then we try to wean when able. Okay, so we want to avoid FiO2s greater than 60% if at all possible, and we want to maintain our PaO2 above 50. And then if you have a flow ventilator, if you have a pressure-driven flow ventilator, and the physician said he wants to know he wants you to calculate the approximate tidal volume you're giving the patient. Okay, so tidal volume equals inspiratory time times flow rate divided by 60. Okay, a good example of this, inspiratory time of 0.4 seconds per breath. Okay, so you have your inspiratory time set at 0.4 seconds. Your flow rate is 8 liters per minute. We have 0.4 times 8 divided by 60 is 0.053333 liters per breath, or 53 milliliters per breath. So if you ever have a physician, you're pressure ventilating, and you know your inspiratory time and you know your flow rate, and they say, what approximate tidal volume are you delivering? Not what are we getting back? Because remember, what's being sent back to the vent isn't accounting for leaks, especially around the ET tube. You can give them approximate tidal volume by doing this calculation. Whew. So here we are, generic initial settings. Generic initial settings. Okay, remember, each neonatologist, each doctor specializing in neonatal medicine will have their own preferences. So this may not work for the doctor that you come in contact with at Children's. But these are generic initial settings. Okay, peak inspiratory pressure 15 to 20. You want to to be high enough to raise the baby's chest, but not so much the baby is literally hovering or bouncing off the bed. We don't want to overinflate and cause more damage. We don't want the baby to be barrel chested. We don't want to give too much pressure, especially with stiff lungs, because then we could get a pneumothorax. So start at 15 to 20 or enough to move the baby's chest, especially if you don't have someone who's been bagging the baby with a pressure manometer. We want to start with our PEEP from 3 to 5. Respiratory rate 40 to 60. And FiO2 the lowest possible to obtain adequate PaO2, right? That's just common sense. We want to be controlled. Okay, so with our adults, where do we start oxygen at? 100%, right? Almost all the time. Not with our neonates. Not with our babies. With our preemies, we want to keep their saturation 88 to 92%. They can tolerate a little bit lower SpO2s. With our term babies, 92 to 95%. Okay, in general, 90 to 92% SpO2 is fine across the board. We start our inspiratory times 0.2 to 0.5 seconds. It seems really short, but we want about a 1 to 2 IE ratio with our babies. Okay, higher rates means lower I time to maintain the correct IDE. And then again, with flow, usually 6 to 8 liters per minute, if you have a ventilator that you can set the flow yourself. Okay, if you don't, the ventilator will adjust based on the respiratory rate and the pressure that you have set. If you have a physician that wants to volume ventilate your baby, very low birth weight babies, 4 to 6 milliliters per kilogram. Now, keep in mind, very low birth weight, this might be 500 grams. 500 grams is 0.5 kilograms. That means you're doing a tidal volume of 2 to 3 milliliters. It's very difficult to measure that. Low birth weight babies, 6 milliliters per kilogram, and term babies, 8 milliliters per kilogram. Okay, so now you can see, kind of think, all right, if we're trying to give a 6 milliliter breath, it's kind of hard for the ventilator to measure that. And that's why we do a lot of pressure ventilation in neonates. Here's an example. Low birth weight baby, 1.2 kilograms. We might start at a respiratory rate of 60, and this is just guessing. FiO2 is 60, flow rate 6 to 8, inspiratory time 0.2 to 0.3 seconds, PIP at 20 to 25, and PEEP starting at 4. Okay, this gives us an IDE of 1 to 3 or 1 to 4, depending on where you set your inspiratory time. Okay, this is just an even starting place. With your PEEP, if your FiO2 required is greater than 60, we want to increase our PEEP. Okay, in pressure ventilation, if you increase your PEEP, and that's the only thing you increase, you don't change your peak inspiratory pressure, only in your PEEP, you are decreasing your tidal volume. If you hold your hands up, PEEP being your lower hand and peak inspiratory pressure being your high hand. Okay, if we increase PEEP alone, we're decreasing our change in pressure or our tidal volume being delivered. If your physician wants to maintain the same tidal volume or the same change in pressure, but also increase the PEEP, you have to also increase the peak inspiratory pressure. You have to increase them both. Increasing PEEP greater than 8 to 10 centimeters of water pressure is excessive. And this is, we're talking about intubated infants, not nasal CPAP, intubated infants, intubated neonates. Okay, if we are more than 8 to 10 centimeters of water pressure, it's considered excessive. We have decreased cardiac output. You have to be very, very careful. Okay, peak inspiratory pressure, if you increase your peak inspiratory pressure, you are increasing your tidal volume and your mean airway pressure. A PIP of 25 to 30, more than 25 to 30 is considered excessive. Okay, so if our peak inspiratory pressures are getting into that 25 to 30 range, we might have to think, just to move the chest, we might have to think about alternative forms of ventilation. Respiratory rates. Okay, we start at 40 to 60. As we go up, our excessive respiratory rates means our inspiratory times have to go down. It increases the chance of air trapping and decreases your tidal volume. So again, have to be mindful of that. Most ventilators, and this puts it all together, are with pressure limited time cycled. Most ventilators are pressure limited time cycle. Okay, so back in the day, there were specific neonatal vents. This right here is called the Secris. We used to have one in our lab. I don't think we have it anymore, but it was an infant only ventilator. You set inspiratory pressure, you set PEEP, you set inspiratory time, and you set flow. Inspiratory time and expiratory time together gave us our rate. These were infant only ventilators. The volume with each breath was variable. Now ventilators will span neonatal through adult. So I mentioned that. Microprocess ventilators, all three of the big ones in our lab will do that. These ventilators and tidal volumes they provide are affected by compliance changes. Okay, so we still do pressure, but if we want to decrease CO2, we have to increase pressure. And when we increase pressure, we're essentially giving more tidal volume. To retain CO2, you need to decrease the pressure, decrease your tidal volume. Pressure changes will affect your CO2 levels more than respiratory rate changes because that baby, hopefully, is breathing on their own. So if they're breathing on their own, you going up or down on their rate is going to have less of an effect on your blood gas than going up and down on your pressure. Okay, if compliance decreases, then the same pressures will deliver lower tidal volumes. Okay, so your ventilator you set your pressure, say at 25. The ventilator is delivering that breath and it gets to 25 and the breath shuts off. Okay, now all of a sudden you've given surfactant and that baby's compliance has increased dramatically. That same pressure of 25 is going to give a bigger tidal volume because the lungs are actually they're inflating more because surface tension is decreased, the lungs are inflating, your compliance is better, and you're getting bigger tidal volumes with the same pressure. So when you give surfactant, you have to be ready to adjust, and you can adjust based on watching the baby's chest. Okay, if their chest has minimal movement, you give surfactant and all of a sudden the chest is bounding off the bed, you need to reduce your pressure so you don't get a pneumothorax. All right, so what mechanical does for an infant? What mechanical ventilation does for an infant? So often it's very temporary, so the baby can transition. Okay, so for whatever reason, that baby's born, they just need some time to transition to adult life. Remember that stable ABGs may not be normal like you think of. Okay, so we can use umbilical lines for several days, but remember that baby has slightly lower values and everything, especially up to an hour of age. We use ventilation to help maintain the elastic properties of the lungs. We want to protect that baby's lungs. We don't want to overinflate them. We don't want them underinflated. We want to optimize it. We want to provide the ability to give surfactant, help decrease work of breathing. stabilize their ABGs or capillary blood gases, which we're going to talk about in just a second. Help maintain their functional residual capacity. Once it's been established, the lungs are inflated. We've given surfactant. We want to maintain the FRC. And then we use capillary heel sticks. So if we don't have an umbilical artery line, the next step in a baby that isn't really, really critically ill is to do capillary blood gases. So we use capillary heel sticks to follow, and we talked about a couple weeks ago, to follow CO2 levels and pH levels. It gives us a really, really nice indication of what the arterial CO2 and pH are. We do not use capillary blood gases to follow oxygen levels, period. If we do not have an arterial line, if we can't get an arterial blood gas, then we use our pulse oximetry and then our capillary blood gas to follow the ventilation side of it. How do we do a capillary blood gas? Well, there's some important things to optimize those values and make sure they're as good as they possibly can be, or as close to arterial as they possibly can be for our pH and CO2. The first thing you're going to do is you're going to arterialize the site. Now, what do I mean by that? I say it in quotes, arterialize the site. We are warming it up and bringing the arterial capillary bed as close to the skin as possible. Okay, we're going to watch a video on this and then we're going to talk a little bit more about it. So we, for capillary heel sticks, we arterialize the site by warming it. We want to get the best, most accurate blood sample possible. We can use the CO2 and pH values on the capillary blood gas. We do not follow PO2 values. And then it actually is proven that oral sucrose, so we can put a little bit of sucrose on the baby's pacifier and have them suck on it, and it causes an increase in endogenous opioids. So the effect lasts for about 5 to 8 minutes, and it only works if it's administered orally, not through an NG tube, not any way else. It has to be inside the mouth, dissolved into the bloodstream, and helping increase those opioids, taking the pain away, the pain sensation away. So some special considerations for infant ventilation. Okay, tubing is a heated wire circuit. We want to minimize to optimally get rid of water in the tubing. Okay, so we have a heated wire circuit. If there's water in the tubing and it sloshes down the lungs, it's a lot bigger problem than in adults, okay? Because babies have teeny tiny lungs. And if you drown them in ventilator water, then you have a whole nother issue going on. That tubing is kept, part of it's kept in the warmer. Okay, so it's really important to make sure that your temperature probes are in and that your heater is working and everything is working optimally to make sure you don't have a lot of tubing right now. Small hospitals often use ventilators that ventilate adults and neonates. Pretty much all hospitals are doing that now. So this point isn't much of a consideration. But still, you might run into some facilities that have infant-only ventilators. Okay, so hospitals that have multi-use ventilators, then all the staff can get way more comfortable and proficient with it, and it's actually a really good thing. And then humidifying gases is super important. You want the gases to be heated and humidified to 37 degrees, because if you're keeping the temperature on your ventilator circuit at 35, when that gas is delivered to the baby has to expend calories to increase the temperature of those gases up to 37 degrees, which is normal body temperature. We don't want babies to expend any more calories than they absolutely have to, because we want them to grow. The only way that they can get better and get off the ventilator is to grow. So if we have the gases heated and humidified 37 degrees, then their body doesn't have to do any extra work to heat up those gases. Some special complications or special considerations. The reason I included this slide, because I know you've heard about all these, but A few years ago, we had a class of students that didn't understand the difference between pneumothorax and pneumomediastinum and pneumopericardium. Okay, so you need to know the definitions of all these things and what they look like on x-ray. So a pneumothorax, okay, pneumo means air in the space of. Okay, so a pneumothorax is air in the space or around the thorax. Okay, anytime unwanted air is present, it's not in the lungs. In pneumothorax, it's surrounding the lungs. Pneumomediastinum, it means air is in the mediastinal space. Pneumopericardium, air in the sac around the heart. Pneumoperitoneum, air in the abdominal cavity. Okay, all of these are serious complications. All of these need to be treated. Subcutaneous emphysema, if you guys haven't felt it, you need to look for it. Okay, it's when there's subcutaneous air. It feels like fine bubble wrap, or like you would think, it feels like Rice Krispies sound. That makes sense. Pulmonary interstitial emphysema. It's air in the interstitial space, little teeny tiny pieces of air in the interstitial space. It forms that ground glass appearance. Pulmonary interstitial emphysema is the first step that leads to bronchopulmonary dysplasia, which is kind of like, it's our chronic infants. BPD are infants that have been ventilated for a long time. Their lungs have a lot of damage because of positive pressure ventilation. It's kind of like COPD for babies. Infections, okay, so anytime you intubate a patient, you're pushing down all the oral flora. Anytime that ET tube passes through the mouth, whatever was in the mouth can go down with it. So we can get infections. And then decreased venous return and decreased cardiac output because of PEEP. Anytime we add pressure to the chest, increased peak inspiratory pressures, increased PEEP. We are increasing all intrapulmonary pressure, decreasing venous return, and decreasing cardiac output. So here's a picture of some of these pneumos. Okay, so here's a pneumothorax. You can very obviously see, here's the lung tissue, here's the air outside of it. Here's pneumoperitoneum. Okay, your diaphragms are way up here. You have air outside of the stomach, the liver. Okay, it's pushing up on the diaphragm. And then pneumopericardium. Okay, so here's the heart. The heart's being compressed. Your lung tissue's out here, and the sac around the heart, the pericardial sac, has air in it. All of those things need to be corrected in order for that baby to have optimal ventilation. Here's pictures of pulmonary interstitial emphysema, collection of gases outside of the normal air passages, but inside the connective tissue of the bronchiovascular sheaths, interlobular septa, and visceral pleura, inside the lungs. Okay, so there's air leaking. It's still inside the lung tissue, but it's leaking out of the airways. Okay, so it's not in the airways going to the alveoli, not all of it at least. Okay, the collection develops as a result of alveolar and terminal bronchial rupture. Okay, so alveoli, one might become over-distended. You know, you have a cluster of alveoli. One or two of them might become over-distended and they might rupture. They're leaking air through inside the lungs, still inside the lung tissue, but outside the normal air passages and inside the connective tissue. It forms this ground glass appearance, and they call it pulmonary interstitial emphysema. Okay, not a good situation for a neonate. And that is it on infant ventilation. If you guys have any questions, please email me, and I will see you in lab.